Hello everyone, welcome to a new episode of Retina Chats. I'm Mohammed Ghanim and with me Dr. Mustafa Manhali.
Hello, everyone.
So today Dr. Mustafa will present a rather difficult case. So let's start.
So, this is a 62-year-old female presented with this kind of opacified IOL, and she had a previous vitrectomy surgery. And she was left on silicone tamponade. She presented with a recent diminution of vision like 3-4 months ago, and on ultrasound it showed that she has a temporal retinal detachment.
Okay.
So the challenge here was to remove this opacified IOL, and as we can see, this lens is fixed in the sclera with sutures. So probably we need to cut the peripheral sutures and to remove the capsular bag without uh, traumatizing more of the iris because of these synechia
So it's
that
a
is
scleral
present.
fixated IOL, right?
Yes,
Okay.
and
And do you usually depend on ultrasound in silicone filled eyes?
usually not, but it's the only tool that can give you a clue what is going on at the back of the eye. And
Okay.
also it's an operator dependent. So if you trust your operator, probably in most of the scenarios, it's going to be uh, fitting what is going on the posterior
Well, it came
segment.
out rather easily. Can you see the sutures preoperatively on the
Yes,
scleral
it's on the
side?
scleral side.
Uh,
Yes.
but usually when it's sutured,
But you will
it's
see now that the opacified part is the capsule and the
okay.
lens is clear, and they are
Okay.
going to come separately now. So this is
Okay.
the opacified capsule.
Mm. So was it necessary to remove the IL, or just if the posterior capsule was opacified, then you would?
Everything was amalgamated, so you cannot separate the capsule and keep the lens. Probably are going to remove it, so
Mm.
you can have a clear view of the
I mean,
posterior
if you
segment.
just eat up the posterior capsule, can you see clearly?
From this opaque media, you cannot even start to open the infusion line, so you
Mm.
cannot start your surgery. So
Okay.
probably you cannot go to do like a posterior capsulotomy or trying to clear up the capsule.
Okay.
And it was not clear that the lens is clean until you have removed this capsule.
Completely.
Yes,
Okay, so you had a look on the retina and you
and I
found that
found
it's
that there is
detached.
a large giant retinal tear in the temporal part.
Okay.
And I think that the macula is not that much affected because of this scarred tissue in
Okay.
the center. So we removed the silicone and we try to. I will finish the anterior segment part and I will implant an artisan lens.
Okay.
Um, Usually I put it in the anterior
Anterior
chamber.
chamber with the retro inclination. Okay, so you took the decision to implant an IL even though that the retina is detached. Would
The
you?
central part is not detached.
Okay,
The
so you
fovea is not
depended
detached.
on the biometry
Yes.
that it's accurate. Okay.
And I was lucky that she had her old biometry that she
Okay.
did at the initial surgery in the other center.
Okay.
So now I've enclavated both haptics of the anterior chamber IOL,
Okay.
and I have stabilized the anterior segment and took my sutures. Then I shifted to air, trying to remove the subretinal fluid and see if there is any shortening. Despite that, depending on the air to see how the retina is flexible or if it is shortened is a very deceiving point. But in this case, it was very obvious that the retina is not going to lie back over the choroid because it's really
So
shortened.
why
So
didn't you choose to put PFCL and flatten the retina and or even stain to look for membranes or
when I
something?
have uh, such a compromised anterior segment and I have an IOL without a bag separating or a diaphragm between the anterior and posterior part, adding much of the oils like PFCL, then shifting to air, then adding a silicone, probably it's going to fog the IOL and it's
Okay.
going to hinder the part that I'm going to do like retinectomy and doing a good laser and can see the periphery as you have such a clear view. So I prefer to do it from the first step under air, so I can keep this clear view without adding much fluids that may
Hinder
vaporize,
visualization.
yeah, and hinder my visualization because of these vapor at the back of the IOL.
Okay.
So just after doing the retinectomy, the retina is relaxed back. I did the laser retinopexy, and I prefer for the horns to secure it with cryo, because
So why do you think the patient had a recurrence? What's the cause?
I think it's a shortened retina in the initial surgery, and probably it needed to be removed or to have a retinectomy at the initial one, or she developed a late PVR that caused this enlarged tear after 3 years of the initial surgery.
Okay. And you left them on silicone again, right?
Yes.
Okay. So what's your tip in injecting silicone in aphakic eyes or in patients with an iris claw lens? When do you know that this is the full fill? How do you avoid silicone coming out to the anterior chamber? Uh, how do you deal with this?
It's completely subjective.
Yeah,
Usually, I put my index over the sclera, and I feel
pressure.
the pressure of the globe. Yes, but sometimes it's not um, uh, obvious for you, or it's not clear where to stop. So sometimes it's an underfill or an overfill. I always tend to be to the overfill side, especially in the aphakic.
You're not afraid that the silicone will prolapse to the anterior chamber?
With this IOL here, it's difficult to come out, because I think this is more stable than the Prolene sutures or the Prolene mesh you can do in the AC. But in aphakic patients, if it is an overfill, probably it can come out to the anterior chamber.
And what about the PI? Did you do a PI here?
Yes, sure.
An inferior one
Uh,
or a superior one?
I did a superior one for the artisan or the iris claw lens.
Okay, but you're not afraid to that
The silicone to come out,
no
to treat it as an aphakic.
yes, and
No,
do an inferior PI.
no, I didn't do this. And
You usually don't do this, right? In
if
these
I add
cases,
an iris claw lens, I don't do the
you just
under.
treat it as a PC IOL, right? And
Yes, it's like a diaphragm.
yeah, and continue surgery as usual. Okay, for me, I don't know. You're the treating physician, but I would have started to do a capsulotomy before taking the decision to remove the IL. Maybe I'm lucky enough to have a good visualization and continue surgery as no, in, as usual. But of course, you are the treating physician. You saw this patient preoperatively, and you had a better clue and a better idea about the media or the clarity of the media before surgery. Um, and if we can see here that the laser treatment wasn't enough in the first surgery, that maybe this is the
In the temporal part.
yeah. So
Yes,
this is the cause of recurrence, and it's not your case, right? It's not you're not the first
no,
surgeon,
no.
so we can't really be sure what's the cause of the recurrence. But overall, I think you had this case, and I hope she did well in the post-operative.
She improved only to 0.05
Okay,
visual acuity, and she's stable, and she's planned
this is a good vision
to
for a
go for a
retina
silicone.
surgeon, right? Yeah. So yeah, it's expected after these recurrences and multiple surgeries to have a vision in the poorer side, but a 0.05 or a 360 vision is what we expect usually in these
In
cases.
such case, when do you remove the silicone
I think at least 6 months of stable retina.
of stable?
At least 6 months of stable retina.
And why do you prolong in such a case? Because the laser mark already is very stiff and strong after 2 weeks. So,
Um,
so are you afraid of a new PVR?
yes, of course. I know that PVR usually happens in the first month or two, and laser scars are stable over a period of 2 weeks. If there is no complications from silicone oil, why not prolong it to 6 months and be more safe?
But
Um,
taking consideration that this is not the first silicon period, because
yeah,
she had a 1.5 years before the presenting to this surgery. So we are talking about a 2 year period of silicon inside the eye.
I usually don't remove silicone oil before 3 months. Once I put silicone oil, this is a case that needs a longer tamponade, so at least 3 months. If there's no problems, no IOP spikes, no silicone in the anterior chamber, no corneal decomposition, no other complications, then I would leave for 6 months. I don't believe that in these cases longer tamponade silicone would affect the final visual acuity. I know there are papers that talking about microvasculature over the fovea, microvasculature in the macula for longer periods of silicone tamponade. But in such a poor visual outcome case, it won't make a difference. So just prolong it, be on the safer side as long as the patient is following up regularly.
And in such a case with aphakia, would you prefer an iris glow lens over a scleral fixation, or
If there is an iris like this case, I would put a scleral fixation. I put an iris crow lens. I don't put scleral fixated IOLs. That's my rule generally. If there is a good iris support, then put an iris claw. Okay.
okay?
So thank you very much for watching. Stay tuned for the next one. Hope you enjoyed this episode.
Thank you.